Well, I'd like to thank the panel once again for, first of all, great discussion, great presentations, and staying on time. So, thank you. And I think we have a moment for some questions. We have some time to... I did want to ask a couple of questions. So the one thing that I keep hearing, and we heard this earlier, is this whole concept of portfolio. We've been talking so far about like individual programs, how do we scale them up and disseminate them, versus really thinking about how do we have a prevention portfolio that's easily accessible to communities. And I think that that's something that maybe I'd like each of you to think about and think about how that you might be able to inform that.
Well, at the Institute for Public Policy, we developed our benefit cost tool over time, and we now actually have this ability to simulate different sets of programs, but it's still very ad hoc. So we kind of talk to providers, we talk to folks at our legislature, and we think, well, what could we realistically do? And then we put all those things in a model together and press a button, and out comes some predicted outcomes for the state over time. So I mean, I would think, putting together a portfolio, there is that kind of attractiveness of the scope of programs, meaning thinking about trying to target multiple populations as well as looking at particular interventions that have multiple outcomes across potentially other topic areas. So I really think that the scope is the most important thing to consider. Not sure how helpful that comment is, but that's where I stand.
So this notion of a portfolio is exactly what was behind our performance partnerships. And we realized, when you bring people at the local level or state level whose job it is to think about the whole child, and they can't do it because of how we're structured, it just breaks your heart. And so certainly I think there's a lot of excitement about the Performance Partnership Authority because it's really an opportunity to say, let's find a target population and test this notion that we can provide a much more holistic set of services. There's a role for evidence in terms of looking at the array of what we know works in terms of education, mental health, job placement or skills training, substance abuse treatment. I mean, all those things, if you're looking at a troubled population, you want to understand how you knit them together and make them work. So we have a chance to try it.
In terms of Medicaid's role, I think you can think about it from the eligibility piece and the services piece. So from the eligibility side, we know that there are a number of children who are eligible but unenrolled. So figuring out how to reach those children and get them connected with coverage is key. And then, of course, among the children who are already covered, making sure that they're being appropriately diagnosed and treated. On the services side, you can see that there's a vast array of services available to states, so it's a matter of states thinking creatively about how to take up some of these new options. The ACA gave states additional options, which we are certainly looking at tracking. So I think it's a very rich benefits package. States sometimes say they want more flexibility and more options within Medicaid, but I think some of the examples that we went through today show that they already have a great deal of flexibility available to them to design their programs.
Pat?
Yeah, hi. I have a question for Mary Beth, and it's a clarification question related to the Medicaid EPSDT. And you had mentioned that under the EPSDT mandate that services have to be provided to correct or ameliorate any physical or mental condition that the child might have. And so as a two-part clarifying question, does mental condition, quote unquote, have to meet diagnostic criteria for a disorder, or can it be a young person who's exhibiting social and emotional challenges to provide services more on the prevention, early intervention type end of helping that child with healthier functioning? And if EPSDT can be used, again, more upstream for a child not having a disorder, what if the indicated service is something like, because you have a family that's in need of a healthier family functioning environment, and what would best suit the needs of that child would be family-based services and supports? will that also pay for the piece of it that involves the parents in addition to the child or as part of the constellation with the child?
Thanks for the easy question.
Okay, so I'm so sorry.
So let's see. So the diagnosis part. So basically, you have to have a provider diagnose you and recommend a treatment service. So long as they're a provider acting within the scope of their authority under state law, that should be enough to trigger EPSDT. Now, the wrinkle is that you need to get the service to fit into one of those categories. So that we have seen litigation in different states around the country. The thing that comes to mind is applied behavioral analysis for kids with autism. You know, some states are saying that's not exactly fitting in one of those categories, and then there have been lawsuits that have gotten that funded. In terms of the family counseling, yes, take a look at, there's a site in the slides too, it's a CMS, I think it's a CMS-SAMHSA joint statement that talks about what different states are doing in that demonstration program, and they, some of them did involve some family service, not just individual therapy focused work. So I think it has been done.
Thank you.
Right.
Stephanie, the work that the Washington State Institute for Public Policy has done around return on investment and cost benefit analysis is just, I mean, it's incredible. I don't think you would find anyone that would argue with the incredible impact that it's had on the field. But it strikes me that this is another situation where we've got a developer with limited capacity to scale up an innovation, right? So I know you get lots of requests from other states to teach them how to do this in their state, or to even give some advice about what variables in the cost-benefit equation are static versus might have to be adapted to a particular state context or the federal context. Is there, has the Institute been approached by the federal government, or have you talked to anyone about how you could scale up this innovation?
Well, at this stage, we actually are working with a joint initiative of the MacArthur Foundation and the Pew Charitable Trusts called Results First. And we've developed our benefit cost model, and it's slightly clunky. It's an Excel-based model, but it's a piece of software. And it has the ability for inputs from other states and then churning out outputs that would be state-specific. So we've provided some assistance to the Results First initiative. They've got a batch of technical consultants that actually are going out to about 15 different states at this stage, working with those states in their state governmental context and trying to see if this approach might work in other places. So that's kind of the current state of affairs. I think there's probably 3 or 4 states who are currently using the model kind of in legislative process, but I don't know how much traction it's got yet, but there are definitely states who are interested and involved in that process.
Ron?
I have just a comment in reaction to the fixed prevention portfolio idea. I think outcomes are necessary. Good outcomes are necessary, but not sufficient. I think good return on investment is necessary, but not sufficient. That we also have to take into account practical, flexible fit of a particular program or set of programs, and also the consumers, the parents, the teachers, the users of the programs, and so on. And so to pre-craft a prevention portfolio strictly on the basis of outcomes and costs would fail to take into account. Just like when you buy a car, you may be able to afford the car. It may get you where you want to go, but the stereo system is not the way you like it, or the seat's not comfortable, or something, but it still operates as a good car. But maybe you want the other car over here, or this car over here, or some combination with features.
Yes.
Observations. So some of the interesting program models that are playing out on social impact bonds. New York City decided they were the first social impact bond where they were going to take kids in Rikers Island and give them cognitive behavioral therapy, I believe. And MDRC and others reviewed all the research and did their best to say, what can we draw from all this research to create something that can work in Rikers Island? But they recognized that there was no perfect fit. So, you know, the pay for success or social impact bond that was implemented had to be their best, most informed judgment. And I think that's the reality of how it plays out on the ground. But the fact that there are these clearinghouses in places like Washington State Institute for Public Policy give you a great starting point.
Yes.
Again, a great set of presentations. I wanted to ask Mary Beth, so when I listened to you talk about potential Medicaid funding, I could almost feel optimistic, except that, like I know in California, all that Medicaid, which is Medi-Cal, is capitated, and the capitated rate is supposed to include that whole bundle, and it's never going to happen. And there's no way there's enough money to cover those services that are mandated. So, is that your impression? Or, because I would listen to you and be optimistic, but it wouldn't be my experience.
Yeah, so in my prior life, before I came to Kaiser, I was a legal services attorney, and I represented people with disabilities, and many of them were children seeking services that their doctors or treating professionals had prescribed that the managed care organization had turned down. So I guess my optimism comes from the fact that when you read the law, it is a very, very rich benefits package with a very generous medical necessity definition for children under EPSDT. In practice, my experience is similar to yours. That was quite a lot of the litigation that I did and that others across the country are doing is holding states and managed care companies' feet to the fire to put this into practice.
Okay, well, I think we're actually on time. Again, thank you to the panel, and I think we want to leave here with hope that there's language out there, that there are tools out there, that we can do something, but there's still a challenge for us to make it practical to our communities. So, thank you.
I want to just thank you all for coming. I have two quick remarks. One is that tomorrow we're going to be back in this room. We were so good today, they said we could have the big room tomorrow. And the other thing is, if anyone is still on the webinar, I just want to let people know that we are going to be contacting those people who signed up via email to ask you for input and feedback on this session and on tomorrow as well. In future forum workshops, we hope to be able to actually make that even more interactive process with people who are not able to be here physically. But at least if you are on the webinar, if you've been on the webinar, you should expect to hear from us, getting your input and suggestions with regard to the forum and the future topics. Beyond that, I just would say, what an incredible day. I learned so much. I just had is swimming with it all. Thank you so much for this day, and we look forward to seeing you tomorrow.